Okay, thank you for joining us, ladies and gentlemen. Today we have Dr. Hassan Malik from Liverpool. He will be talking about the surgical management in the palliative setting. Thank you, Dr. Hassan, for joining us, and the floor is yours.
Thanks again. Thank you very much. So this is a bit of my own personal thoughts and views. It'll be interesting to see what the audience thinks. Anyway, so all this started with a kind of odd referral letter. Can you help? We don't know what else to do, basically. And this was just before Christmas time. And this was the patient when they arrived. He had a large fistulating tumor. Now, if you look at the 4 basic principles of cancer treatment, it comes down to prevent all cancers you can prevent, treat all cancers you can treat, cure the group of cancers you can cure, and obviously provide palliation when palliation is required. And I would say the surgeon has a role in all of these aspects of cancer care. But the focus today is really in the last bit, which is about palliation. So what factors do we normally consider as surgical oncologists? Well, you've seen me give this talk before on different tumor types, and it's about defining resectability of the cancer, whether it be a sarcoma, whether it be liver cancer. Obviously, the prognostic aspects, the chance of long-term cure, and then obviously your own personal results, the ability of your team to manage these cases, and the patient comorbidities. And so you can obviously stratify patients based on that. So how can this algorithm be modified in the palliative setting? And the prognosis is limited. So essentially, what factors do we need to consider in this scenario? So first of all, we have to look at the viable surgical options. They may be debulking, they may be bypass, they may be formation of a stoma. Most of what I'm discussing is around GI cancer or GI tract. It's not about urology and other aspects of palliative surgery. What are the aims? To deal with pain, obstruction, active bleeding, symptomatic anemia possibly. And I think patient choice is important here as well. And it takes into account patient fitness and expected improvement in quality of life. And what are the other non-surgical options that exist? Because obviously they have to be first explored. So this is really coming down to this concept of shared decision-making, which is a partnership between the patient and the clinician and the family, etc. So the broad indications for surgery in the palliative setting are in the emergency situation, which can be acute bleeding, obstruction, or perforation, but also improving quality of life, and thus helping manage pain, diversion of GI contents from a fistula, control of symptomatic anemia, commonly with a GI cancer, and in nutritional support, so access, for example, PEG, jejunostomy, feeding, Hickman lines, etc. But also, as surgeons, you can facilitate further oncological management. And this could be to access something simple like a biopsy. If it's not accessible by radiology or endoscopic ultrasound, you may need to do a laparoscopic biopsy, for example. What about the resection of oligometastatic disease or Olo Progressive disease to give chemo holidays? Or insertion of chemotherapy infusion pumps? Or in the US, they use silicone spacers to facilitate radiotherapy, for example, in the pelvis. So in this particular case, what happened next? Well, this is a gentleman who had been treated initially in New Zealand with a retroperitoneal sarcoma about 10 years back. And then he'd gone to a big centre in London and had recurrent surgery there, and then relapsed further. And was then said, look, there's nothing we can do, just go spend whatever time you have with your family. And he'd come to the northwest of England to visit family. And he'd been admitted to the local hospital with an abdominal wall abscess, which was drained. And clearly it wasn't an abscess, it was a tumor, and the tumor fistulated. So what we did is we admitted the patient for optimization with TPN. And we'd planned a multivisceral resection of this sarcoma. Upon the eve of the surgery, the patient had a major bleed and then had to go as an emergency to have this operation. You can see the scan there, the CT, showing the exophytic tumor involving the right iliac fossa, the gut, mainly the right colon, anterior abdominal wall. And we are basically excised with a wide margin, the abdominal wall and the colon. And then did an anastomosis and then covered this with a biologic mesh. In terms of the special circumstances for these type of cases, you can have the emergency scenario. And the commonest here we're talking about is small bowel obstruction, really. And this is the data, very old data in the UK from the National Small Bowel Obstruction Audit, which was taken over 6 months. Over 2,000 patients enrolled. 10% of these obstructions were secondary to cancer. About a third had a stoma if they had an operation. 3% were managed palliatively, and that included patients with carcinomatosis. The in-hospital mortality was 8%. But there was no long-term data in terms of what happened to these patients in terms of outcomes. The malignant small bowel obstruction can occur in about 15% of patients, commonly in patients with colorectal cancer, ovarian, or gastric cancer. This obstruction can, however, spontaneously resolve in about a third of patients, and you can use gastrografin studies to try and, not just as a diagnostic, but as a therapeutic tool. But the median survival is often several months, even in patients managed palliatively. So if they arrive in your ED and things, it doesn't mean they're doomed, and they'll die on that admission. People can, if treated appropriately, survive and live beyond for at least some time and get some further treatment. And to die miserably in a hospital, with obstruction, when you can deal with obstruction, get the patient home to be with their family, that perhaps gives them some dignity in whatever time they have left. What about improving quality of life? Well, this is looking at cytoreduction for HIPEC. Again, obviously this is an area that some of you have far more experience than I have. But although the quality of life after cytoreductive surgery initially falls, it does rebound after a few months. And certainly the quality of life for those who survive is comparable, to their baseline before the operation. Debulking surgery, again, is something that is discussed and considered. This is probably the second sarcoma I did with Professor Poston, who was my senior colleague at the time, a young man who saw his abdomen grow over a period of 6 months. And this was a 20-kilogram tumor, which we removed. And if you look at the retroperitoneal sarcoma, now this is an old talk, an old data. We now have done probably over 230 resections for retroperitoneal sarcoma in around 150 patients, around that amount. And yes, you can do vascular resections. We've actually done 17 IVC resections, 3 iliac artery resections, 2 aortic resections, which isn't mentioned here, and a number of HPB resections, etc. When you look at the data, it seems to be reasonable compared to the national registry data in the UK. And this is an example of a patient who was referred again as a tertiary opinion from a centre down south, who had an endometrial sarcoma, and she had involvement of the incisional hernia with tumour nodules, etc. And we did a laparotomy, did cytoreductive surgery, essentially a kind of sugar baker type operation, and pelvic peritoneectomy. You can see there colon, spleen resection, a mentectomy. Formed a stoma and repaired the incisional hernia, and she lived several years after this. So again, this is some old data from Liverpool. You can see on the right-hand side, I don't know if you're able to see that on the screen with the hepatic and IVC resection. So we can do some complex stuff for recurrent sarcomas. And essentially, when you look at, this is data for our overall survival for single and then multiple resections. You can do the resection once, and you can do re-resections for recurrent cancer. And this is controversial because a lot of centers will not re-resect recurrent sarcoma. But this is now data published from the Transatlantic and Australasian Retroperitoneal Sarcoma Collaborative. And they looked at a lot of data on recurrent sarcoma. They found a number of factors that predict outcome. And the overall 6-year survival was still over 50%. So certainly worth considering in a select group of patients. What about oligometastatic disease? Well, half of my job is as a liver surgeon. This is the data you have for resection of colorectal liver metastases. This is similar to most of the big series. But then if you have other primary tumors causing oligometastatic disease, you can see the outcomes in select patients, I have to say, can be consistently good. And that's in breast cancer, in sarcoma, and that includes GIST, comparable, if not better, than colorectal liver mets. In melanoma, ocular melanoma in particular, the survival is reasonable. There's very few other therapeutic options for that. And interestingly, in esophagogastric cancer, is again, reasonable results. But most of these are for gastric liver metastases rather than esophageal. But for pancreas, as far as we know, results are very poor. And there's a number of ongoing randomized trials looking at pancreas in particular, but not something one would recommend doing out with a trial. So you can resect oligometastatic disease, but what about oligoprogressive disease? In fact, today, I've seen a young man who has a germ cell tumor, extensive liver replacement with cancer, and he has pulmonary and intra-abdominal disease, and not surgically resectable. All sites you can't resect it. But he's had a fantastic result to chemotherapy. And in his PET scan, he has 2 areas of avidity, one in a retroperitoneal mass and one in a liver metastasis, which is at the edge of a large metastatic mass within the liver. So the plan for this man, after discussion with the oncology team, is to resect the retroperitoneal mass and ablate that site of PET-avid disease. So this is really dealing with oligoprogressive disease, a different concept, and have a completely separate talk on management of oligometastatic disease, which I've done before and happy to do again. The key thing here is you have to select your patients. This is data, a paper from Rene Adam, 20, 30 years old, which looked at the prognostic factors. And this was, whether you can get an RNO resection, whether the patient is young and fit, whether they have extrahepatic disease. This is really talking about liver oligometastatic disease and the site of the primary tumor. But these are all factors that Virchow would have understood in the 1800s. Now, what about, so we really need to look at the biology of cancer in a more clever way. That's basically the point of that slide. And what about the patient who has multi-site disease but is asymptomatic? Well, we have this data from the Netherlands Cancer Registry, looked at over 2,700 patients who underwent a palliative resection in the asymptomatic setting. And essentially what they found is that resection in the palliative asymptomatic setting did seem to favor, so it's favored over palliative chemotherapy alone. There's a number of randomized trials that have been running for some time. They're all due to report and haven't reported yet as far as I know. But there has been 2 small RCTs which have shown negative results. A handful of patients, 50 odd in one and about 100 in the other. So quite small trials, but they were both negative. So perhaps we shouldn't be resecting an asymptomatic primary tumor in the palliative setting. And the new European consensus on the management of synchronous liver metastases, which is another talk, which I'll do next time, does say we shouldn't be doing that. But the interesting question is this: what about liver transplantation? So we have patients now in the UK have access to liver transplantation. And the recruitment criteria for that is inoperable metastatic disease. So they would fit the bill here of, incurable, inoperable disease, okay? Because we can't resect them. They have to be stable on chemo, okay, great. But you also have to have the primary tumor resected. So we have this difficult situation in the UK now that to get a liver transplant, we have to resect the asymptomatic primary tumor in the palliative setting, which is kind of the opposite of what I'm trying to say here. So that is an issue that needs to be addressed. So in conclusion, I think palliative surgery may improve quality of life and enables further oncological options and avoidance, crucially, of emergency presentation of cancer. Surgery can also facilitate end-of-life care in the home or community setting. However, these patients are not under a defined surgical specialty. Often a presentation, they present as an emergency. And so the question is, and it may be an easier question to answer in Egypt, where you have surgical oncology as a specialty and you have cancer centres, unlike the UK, is do we need to incorporate the holistic aspect of palliative care with the surgical training? And certainly in the US, where surgical oncology is a recognized specialty, there are a small group of surgical oncologists who are also dual accredited in palliative care treatment. And that combination is, I think, a very interesting combination. And certainly, as a lot of our patients will unfortunately die of their cancer and maybe present as an emergency before they die, it is something we as a community need to think about. Thank you much. I think that's pretty much it. The last bit was just to say we really need what I've just said. Need MDTs, and we also need the surgical oncologist to be, made part of the palliative care services. So finishing off, it's always important to expect the unexpected. Expect surprises. I always do. And this is that man I showed 5 years later. I was locked in as well.
Nice picture.
Thanks.
Okay, we can start by taking questions. Please, if you have a question, raise your hand. We start with Dr. Madhat Kafaga.
You're muted.
We can't hear you, Dr. Madhat.
Can hear that?
Yes.
Okay. Thank you, Dr. Hassan, for this very good. Do you agree about euthanasia in such patients? And if you agree about it, what's your indication for it? You know what I mean, euthanasia.
Agree about?
It's killing of these patients.
So
Euthanasia.
Okay, good.
This is
yes.
You understand it?
Yeah.
Okay. You approve it. What is your indication?
Yes. So in the UK, it's illegal. Okay.
It's illegal. Okay.
It's illegal in the UK. It is legal in some European countries, like Holland. I think it is legal.
Yes.
But it is something that I think the patient, I don't know the Dutch system, but I believe the patient can request it. It's not something that the doctor ever prescribes. As a Muslim, I don't believe in this as a I don't believe in it as a Muslim. But I thank God I'm not in that position as a human being myself to see, God forbid, my family, myself in that position. It's very difficult for me to say yes or no because I'm not in that position. But in the UK, it is illegal. What we can do
illegal.
Illegal.
In UK, illegal.
Illegal, yes. Illegal.
It's not like Holland.
No.
In Holland, it is legal.
Yes, and in some other European countries, Switzerland, I think, but no, in this country, no, in the UK is illegal. Yeah. Mm-hmm. Well, we can help people. We can help control pain, can help deal with symptoms, can try and help, but it's not legal, no.
Thank you.
Nice question. Any other questions? Please, if you have a question, raise your hand. Dr. Mustafa.
Thanks, Dr. Hassan, for this elegant presentation. Dr. Hassan, do you believe in palliative resection in advanced pancreatic cancer, either local advanced or metastatic disease?
So I'm not a pancreatic surgeon, so I do mainly liver and sarcoma. I think pancreas cancer, even the non-palliative resections outcomes are very bad, in terms of long-term cure rate and things. And the morbidity from pancreatic resection is again very high. So the idea of doing a resection in the metastatic setting, I think, is not logical up front, obviously. It may be done by mistake if someone goes in to do a resection and they find mets and okay, we'll just resect the mets. But I think when I looked at the oligometastatic data, the pancreas is the one group that do very badly. And my impression is that these patients are better served by radical systemic treatment, like triplets, FOLFIRINOX or whatever. And then if there's disease control, after a long, long period of time, months, then maybe have a discussion, But up front, no. But the thing with palliative resection is the whole point about palliative treatment is about symptom control. And it's not about improving long-term survival. So yes. It's important so how can we manage the symptoms? Well, we can manage the obstruction with stenting or either biliary or duodenal. But you may have a situation where the duodenal stent fails and you need to do a gastrojudge, etc. So that would be a less morbid operation than a resection operation, for example. So I think you have to look at all the options and it has to be done. This is why I think it's important for these patients to be managed in a proper tumor board with experienced surgeons and clinician oncologists and palliative care physicians and things to see what are all the treatment options together and then come up with a potential plan. I mean, I had a very difficult case recently, a young lady in her 50s with a recurrent retroperitoneal sarcoma, high-grade sarcoma. She had her initial surgery about 10 years ago in one center in the UK. Then she developed recurrence several years later, went to a large center in London, had surgery for recurrence, and then recurred again. And she'd been living with this recurrence for about 4 years, having various treatments and various lines of treatment and all that. But for the last 3 months, she'd been presented with gastric outlet obstruction. And they'd done an endoscopy and a tumor had fistulated into the duodenum, causing a complete obstruction. She had ongoing hematemesis, dropping her hemoglobin to 5, sepsis as well, because the tumor was necrotic. And she'd been like this for like 2-3 months. And they discussed the case in that center, and they said, look, shouldn't be doing anything. And you're probably right, but another opinion was sought. We saw the lady up in Liverpool, and we said, look, what we can do potentially is an emergency operation to save your life. The aim is not to cure, but just to save her life. And the tumor was big and involving the small bowel mesentery and things. We ended up doing a subtotal colectomy, palliative resection, pancreas preserving resection, the third part of the duodenum. She had peritoneal disease. We did a primary duodenal anastomosis, brought out an endstoma. She was in hospital for about a month, but when she left, she was able to walk, she was able to eat, because she couldn't walk with this mass in her abdomen, She's clearly progressed again, and she should probably go back onto palliative chemotherapy, but the aim of that operation was never to give her years of life. It was to deal with an acute emergency, to deal with the GI obstruction, because there's no other way to do that. You could not stent that, so that needed this type of operation, or you just give the patient supportive care and they just die of a massive bleed or something like that, or just so that's the key thing. Is I think none of these are life extending operations beyond that immediate risk of death because of an acute problem like a bleed or a perforation, but they're about giving a patient some dignity and time with the family so they can die in peace. They'll all eventually die. The patient I discussed was exceptional. The man who survived many years after that operation was an exception, but that's one anecdote. It's not necessarily, every patient will be like that.
Okay. Dr. Medhat?
Yes. Dr. Hassan, what is the minimal life expectancy during which you're allowed to do surgery for these patients? Is it 3 months, 2 months, 1 month?
I don't think there's any rules.
There's no rules. Okay.
And, I do not control when someone dies.
Okay.
It's up to Allah, okay?
How about when you remove a big tumor, the concomitant immunity usually drops, and it may enhance the growth of the tumor.
Yeah.
Because you are removing the stimulus for concomitant immunity. What do you think about that?
Yeah, certainly I see scenarios where I see it in liver surgery is quite an important issue because the liver regenerates and hypertrophies, and if you've got microscopic disease in the future remnant liver, as it grows, you see tumors elsewhere rapidly growing. So I think it is a genuine thing. I think, going back to the first question, I think the important thing is this, that you have to have a discussion with the patient and the anaesthetist and the family and the intensive care, etc. Is no point taking a patient to theatre if they're in such an extreme situation that they're literally dying today and they are so frail that at the end of the life, and there's no point doing that. Okay, so you have to be in a position where the patient is fit enough to come through the operation. That's important. They need to be able to survive the laparotomy. And then what happens next, it all depends on what you find and what strategies you can have, bypass, stoma, whatever you need to do. But they need to be strong enough and fit enough to have an operation. And if they're not, then you manage patients with best supportive care and whatever analgesics or whatever they require. They have to be fit enough. But there's no rule that the expected prognosis is X, Y, or Z. But where that type of discussion is important is that if you take this patient to theatre, the intensive care doctors will want to know what the expected prognosis is in terms of supporting that patient. If your surgery goes very well and the patient's stable, they go back to the ward, everything's fine. But the problem is if the surgery doesn't go well and the patient has organ failure, then a difficult conversation has to be had about level of care and escalation of care. And that's where a predicted prognosis may well be something that you have to factor in. And this lady I mentioned, she'd been living with her recurrent cancer for many years, and we haven't cured her. All we did is give her a GI continuity back, and then she can go on and have further palliative chemotherapy, and she'll eventually die of this cancer. She'll die before the end of the year, I think.
Thank you. How about admitting terminal patients to the ICU? Do you agree about that? Because where I was trained in Memorial Sloan Kettering for 3 years as a fellow and resident, it is not allowed to put these patients in the ICU in the terminal setting.
No, they won't do it.
It's a mistake to put them in the... contrary, in Egypt here, they put these patients in the ICU, which I don't agree to.
No, I mean, I think... so ICU admission is controlled by the intensive care doctors in the UK, not by surgeons. So I have no control over what ICU admit. And once the patient is there, they have complete ownership of that patient's management. I can advise, I can do whatever, but they will decide. I see no point in taking someone who is terminally ill, who's dying, and putting them into intensive care. That's a very valuable resource. There's not enough intensive care beds in the UK. And there's no point. But you'll have a situation of an end-of-life type care patient in whom you've undertaken an operation like what I've described in the emergency, probably the emergency setting rather than an elective setting. And then it would be reasonable for them to go to intensive care and have support for a number of days and a bar in terms of escalation of treatment. So, you may provide inotropes, but not mechanical ventilation, for example. You may not provide renal replacement therapy, stuff like that. And that would be reasonable because you have to support the person you've operated on. But taking someone who's just dying naturally to ICU, there's no point in that.
Thank you.
Dr. Munir Abu Ala.
صوتي مسموع؟
Yes.
Yes.
Yes. Professor Khafagi asked about euthanasia, the mercy killing in which the doctor takes an active part. Now I ask a nearby or similar question. What is about physician-assisted suicide?
This is euthanasia.
No. Euthanasia in which the doctor takes an active part, give the patient an injection of potassium chloride, for example.
Okay.
But the physician-assisted suicide, he may tell the patient, you can take so and so, but will not take an active part. Just tell the patient.
Advice, you mean advice?
Advice, certain tablets, certain whatever. So it is called physician-assisted suicide.
Yeah, all of this is illegal in the UK. I mean, there have been scenarios where, for example, a husband helps the wife to die. This is what you're describing, and they have been arrested. So in the UK, none of this is legal, no. So the UK has very strong laws about this. It does not allow it. I mean, there are people in the UK who will go to Europe to some centres. There's, I think, Dignitas is one. They will travel to Europe and they will go there to die. Okay, but in the UK, it's not legal. Whether you do it yourself or as a doctor or you advise or whatever, it's not legal.
Okay. Any more
It's not
questions?
legal in Egypt either. Yeah.
Yes.
I think it's an interesting area, and we see these patients, unfortunately, all the time. And my problem is that they're often dealt with as an emergency, and I just wonder whether we can do it better, and having a different, more holistic way of thinking about it and having the surgeon involved. Now, I'm not talking, and I'm not supporting the idea that we become very radical with surgery in these cases. That's not what I'm saying. All I'm saying is the surgery may have a role, but it explains possible roles and shared my experience. I think these patients can hopefully be helped if we work in a more consistent way. And I think this idea that I've seen from the US of this kind of dual accreditation of being a palliative care accredited and surgical oncology accredited, I think is a very interesting model.
Okay, great. So I think we don't have any more questions. Any questions? Any last questions before we go? Okay, so I think that was it. Thank you, Dr. Hassan. It was an honor to have you with us.
Pleasure as ever. And we'll set another time, and I'll go through the guidelines for the management synchronous meds, the European guidelines.
Okay, so tomorrow I will send you the video from today, and I'll send you the few available dates, and you can choose pick a date.
Great, excellent. Thanks.
Okay, thank you, and good night, everyone. See you next week. Good night. Bye bye.